Thank you. Will be placed into the conference.
Hello?
Yeah.
Charles.
The conference has been muted.
Hello, good afternoon. Welcome to today's webinar entitled Leading Change in Long-Term Care, Embedding Nursing Order Sets in PointClickCare, presented by Deborah Johnson. Deborah Johnson received her undergraduate degree from the University of Toronto and then went on to complete her master's degree in nursing at Athabasca University. Debbie also has her green belt in Lean Six Sigma and is a certified excellence professional through Excellence Canada. Debbie has worked in long-term care over 15 years. Debbie has worked as a floor nurse, direct care, and currently is the Director of Professional Development and Informatics with Chartwell Retirement Residence. Chartwell, Debbie is responsible for policy and development, optimizing the use of PointClickCare, supporting MDS, as well as quality and quality improvement activities at Chartwell long-term care homes. Please note that this webinar will be recorded and today's participants will receive an email with instructions on how to access the recorded link, which will be saved and posted to the RNAO Communities of Practice and website. At this time, all participants are in listening mode and automatically muted for the presentation portion of the session. There will be an opportunity for asking questions at the end of the presentation, and there are two ways to do so. The first option is to type your question into the chat box on your screen, and the second option is to unmute your line by pressing *7 and ask a question verbally. We'll also be doing a formal evaluation survey at the end of the presentation. We only ask that you stay until the end to complete the 6 short survey questions. Thank you, and I'll turn it over to Debbie to begin. Debbie, just a reminder to please press *7 to unmute your line.
Oh, everyone, thank you, Tanya, for that introduction, and I'd like to welcome everybody to today's webinar. Just on the outset, I wanted to, we'll be talking about some features in PointClickCare, and I'm going from the perspective that people will have a basic understanding about how to actually build assessments in PointClickCare. We're not going to be talking about the basic application, but how we actually use PointClickCare and the features there to embed the RNAO nursing order sets into PCC. Just wanted to clarify that up front. So the presentation objectives for today's session is to review the best practices for embedding RNAO ICMP encoded nursing order sets within PointClickCare. And this supports technology-enabled data collection and data extraction for an outcome evaluation. And I just also wanted to point out that my screenshots are taken from a training environment that we have access to for PointClickCare, so it is all dummy data that you're going to be seeing. So first, I'd like to thank Canada Infoway for funding this initiative. They've been on board since day one with us, and it's been it's been a pleasure actually working with the Canada Infoway people. Everybody brings a different perspective to the project, and their insight has been invaluable. And most importantly, thank you to RNAO for sponsoring this collaborative and for including Chartwell in this opportunity. We've learned a lot, we've experienced a lot, and we continue to have fun with this project. So just a big thank you to RNAO for their continued support for clinical practice and ensuring clinical best practice in long-term care. So the partnership that was formed for this collaborative, it was formed using a nurse peer leader network and started off in January 2016 with this project, and it's part of the Canada Health Infoway Clinician Peer Network that operates in Canada. RNAO recruited the nurse peer leaders and the participating health organizations through a request for proposal process. And Chartwell Retirement Residence is one of 4 organizations that is participating in this project. We actually have at Chartwell 2 sites that are in the project. We have 27 long-term care homes across the province of Ontario that we either own and or manage. two sites that we selected for this project. The first is Chartwell London, located in London, Ontario, and it has 95 long-term care beds. And the other home that we selected was Chartwell Waterford, 169 beds, so bigger home, located in Oakville. And both of these homes, as you can see from the small little pictures there, they're both the A-class homes, so the newer build homes. Both have 100% occupancy, so we have a great population for our project. So here's a nursing order set. Nursing order sets are really gaining attention in long-term care. And for example, recently we had Minister Hoskin announce a change to the Long-Term Care Homes Act, the associated regulations that are going to support the Ministry of Health, their ability to actually direct long-term care homes to use nursing order sets. We have a lot of further information in the sector about this right now. However, I must say the RNAO nursing order sets have been extremely comprehensive, and they are based on their best practice guidelines. So we feel like we've had a little advanced practice on implementing order sets at Chartwell. So an order set is a knowledge translation tool that takes clinical best practice guidelines and it embeds it into that tool. We then use that to order that to then embed that within the electronic health information system. You can also use the order set in a paper-based environment, but what you'll see from the presentation is we're using PCC and embedding it into your electronic health information system. You can capitalize on the features that are within your electronic health system that make the reporting and the data that comes out of your nursing order sets far more robust and far more applicable in the clinical environment. So order sets also provide content for clinical decision support logic to trigger interventions based on specific parameters. They can generate alerts and reminders to enhance patient, client, resident safety and aid decision-making at the point of care. Our nurses really found that these order sets have, as one nurse said to me, they've become my best friend because I know when I use it that I'm doing everything that I can possibly do for my resident who has a pressure injury. So in terms of the implementation context at Chartwell, we use PointClickCare across all of our homes. And so the order sets that we selected to work with were the assessment management of pressure injuries for the interprofessional team, risk assessment, prevention for pressure injuries, and strategies to support self-management in chronic conditions, collaboration with clients. And I'll talk about that one just for a second now, because one of the things that Rob was a little skeptical on when we first went into this project was the whole collaboration with our clients, believing that many of our residents have a capability to engage with us in self-care of a chronic condition. But boy, were we surprised, and it's one of the wow moments for us go to this project. So again, a big thank you to RNAO for pushing us forward with this. Our implementation team, we carefully selected and knew the homes that were going to be involved. We first looked at our corporate level, and we looked at what people from there could be selected. So as the Director of Professional Development, I am the nurse Peter that's leading the entire implementation at Chartwell. And we also then selected two other corporate team members. One was a nurse consultant who had extensive skin and wound care expertise. So she was brought on. She also had extensive experience with education, and that was going to be a large component of what we were doing. So she was a very valuable asset to our team. And then also our corporate PCC database manager, because building the order sets and embedding them within PCC was also going to fall very much on her. The benefit being she is an RPN, so she has frontline clinical experience in long-term care. So not only was she able to build the material for us in PointClickCare, but she was also able to contribute very significantly to clinically and to workflow processes in long-term care. So she was an extremely, and she continues to be an extremely valuable team member. Then we needed to have nurse peer leaders at our two homes. Oakville and London are a little distance apart, so it did make kind of supporting the two homes, couldn't do it in the same day. So we engaged with our directors of care at Chartwell Waterford and Chartwell London, and nurse peer leaders in those homes leading the team of frontline staff. We also had on the in-home group, we pulled and relied very heavily on our skincare coordinators, again, believing that we needed to engage the staff who do the work to help us design the work, because those staff know the workflow and the work processes the best. So this could be a corporate design of how we were going to embed them. The order sets, we needed to have that frontline staff involved. And we did also bring in some of our frontline registered staff as that check and validation. Does this make sense? Is this going to work? Now, of course, best-laid plans work very well. However, when consultants with wound care expertise opt to opt for another wonderful opportunity, we had one of our key team members drop off. So my involvement was to be more high level. I've now taken on that role and kind of leading the charge at Chartwell. So our team has continued to grow very strong through this project, and they're exceptionally committed to the work. So let's first look at what are the various areas of a nursing order set. I don't know how many of you on the line have actually seen one of RNAO's nursing order sets. But the first step in embedding the nursing order set within an electronic health information system is really to become very familiar with the various components of the order set. And you'll see some of these. There's 6 of these components that are highlighted on this screenshot, and they display various subsets of the nursing order set. This one's taken from the assessment and management of pressure injuries, so it's a snippet from the actual order set. So in section number 1, this is the assessment section. It contains all interventions to guide the clinical assessments. For example, assess the pressure injury using a validated wound assessment tool. Now, 2, the planning section then also speaks to the various interventions that you would want to have incorporated into your care planning process to guide the care planning for a resident with a pressure injury. Part of the order set is the implementation. So the implementation section contains interventions to support the delivery of care. And the example here that you're able to see is reposition the resident every 2 to 4 hours. And number 5 shows you associated documents and various alerts. So there are linkages that take you to another document or another assessment tool that you can use as a resource. And the algorithms that these links take you to, they are all published in the best practice guideline document from RNAO. And sources provide additional information to the nurse to enhance their clinical decision-making and really promote optimal client outcomes. 5B, you'll also see alerts in the system, and that's, you'll see it in the red, where it's alert, only use the new NPUAP on initial assessment to describe a worsening pressure injury. It's kind of that flashing thing in your eye, and that's a means of notifying the care providers of conditions that could potentially jeopardize your resident or patient safety. And the big change for us and the big learning for our staff is around what ICMP codes are. So ICMP stands for the International Classification for Nursing Practice. And ICMP codes are standardized terminology language that has been developed by the International Council of Nurses. ICMP codes are 8-digit numbers and are at the end of the intervention statements. The ICMP codes facilitate technology-enabled data collection and data extraction for outcome evaluation. So we have to explain to our staff what ICMP codes were. We spent considerable time in the training reinforcing that ICMP codes are different from ICD codes for diagnosis, and that really the ICMP codes are what and demonstrate nursing practice. In the design and build, first, the key message we heard from our staff when we started actually talking about the project with RNAO and getting people excited because we wanted to build some energy for the project. The message that we heard back from our frontline staff is, please don't duplicate work. Please ensure that you're streamlining and simplifying where necessary, and make sure that if we're doing something for the nursing order set, we're not duplicating it somewhere else in previous assessment or process that we had developed through policy and procedure. So our design of our project, we were constantly checking in with Chartwell policy because we needed to make sure that what we were going to be doing would align with policy, or did we need to have policy changed in these two homes to support the project that we were doing. And the good news is we did have to have a couple of policy changes, but I the policies for Chartwell, so that made sure that the policies got done at the same time that we were working through our process within Chartwell of how we're going to do the build. We also checked in regularly with the RI coordinator because MDS 2.0 and the assessments are a very large part of what we do in long-term care. We needed to ensure that where possible, what we were building and designing aligned with and was complementary to the MDS and the MDS outcomes that are being built. Also looked at the Long-Term Care Home Act, of course, the regulations. We also looked at the inspection protocols around skin and wound to make sure that what we were considering doing would be in alignment and complementary to what the information you find in the inspection protocols in long-term care. And most importantly, we engaged with our frontline staff. We asked them to describe a number of different scenarios related to residents with skin and wounds, such as what did they do for a new admission, what happens at the quarterly review process. I wanted to hear from the staff what their workflow was so that we made sure we weren't adding work and we weren't duplicating work. So it was, what can we take away, what can we refine, because we know how busy everybody is in healthcare and that we don't have a ton of long-term, of extra time to be spending doing duplicate processes. This is a worksheet that we developed. We needed some way to look at, and because people started, as we got frontline staff involved, people started, just having these random ideas, and we needed some way to kind of quantify and document. So we actually put our fingers to the keyboard. And what we did was we took the order set, and in an Excel document, we divided the various columns, and we had one for the ICMP code. Again, we needed to keep that front and center with what we're doing because that was going to be our way that we were going to be able to report off of the work we do. We looked at what the intervention was in the actual nursing order set, as well as we documented all of the associated documents because those were best practice recommendations around other assessments and tools that you can use in you're working through assessment of residents with pressure injuries. Then developed a column which was the Chartwell assessment. So we're currently doing that would align with that intervention. And didn't have something, then we would look to the associated document as a new tool or a new system that we could actually implement at Chartwell. So it was an excellent exercise to align us and really help us focus on where do we have to support education, where did we have to do new things, where could we take some of what we were doing away because it was already included in the order set. Okay, so we also had to tap into our interprofessional partners. For example, in the last row on this screenshot, it's screened for nutrition using a validated screening tool. So we do have nutritional screening in long-term care. We have a nutrition risk assessment, but we also have a corporate dietitian, and we want to bring her into the project, have her review this area of the order set and say, are we good? Do we have to add anything to our nutritional assessment, or are we good to go forward? We also looked at bringing our PT for certain areas of the order set, our OT as well, so that we made sure that before we ever started building anything in PCC, we had a plan and we had a map to go forward. Okay, so next slide. So once we got everything aligned and we knew kind of the direction we were going to go in PCC in terms of content, this is where the rubber hits the road, and we needed to figure out where we were going to build the order sets in PointClickCare. And we had three options that were initially identified. We could build them as an order template in the Orders tab. We could do them as part of the care plan library, or we could build this using a user-defined assessment. We actually started down the road adding the various statements to the care plan library. So we were looking at making this part of our overall care plan library. And the nurses could then, as they built the care plans, indicate what's being done or what should be done based on the order set. However, once I started working through what would happen and the actual workflow and the work process that the staff would have to follow to identify the items that are the order set and what needs to go into the care plan, really started thinking that perhaps this wasn't the best approach and it was a little too complex and putting the cart before the horse. So it was very difficult for them to isolate all the items in the order set to ensure that they were addressed because they were part of a much larger care plan library. So at this point, we kind of did the halt. We went back to the drawing board to reassess what our other options were because the whole group more or less identified that that wasn't going to work. So then we thought an order template might be good in the Orders tab in PCC. Once we kind of did a review of some of the Orders tab, the staff just felt it would get buried in with all of the other medication orders, diet orders, et cetera, that are in that tab. So not easy to report off of in that area and not easy to isolate. So that's with the user-defined assessment. And this is where, once we got going and we really did the aha moment, this is it. With the new functionality that PCC has in their user-defined assessment build area, with the show guide option, the auto-populate options, we felt that we had a lot of functionality here that we could really capitalize on when we went to do build of order sets. So the group spent considerable time talking about the various features. So we looked at every single statement in the order set and said, how do we want this to function in our database? And our database manager was the one who really led this discussion because she was going to have to go away and build this. She really needed to understand what the staff were looking for and how this was going to work. So when we got through the first one, off she went to start the build. And we set up regular check-in meetings with her. We didn't want to get too far into the build of it, with validating back with our frontline staff and our skincare coordinators that this was in fact what they were looking to do and they were looking to have at the end of the build. So we knew that there would be some point after we went live that we may have to recircle and go back to the build because things didn't really play out the way that they should have in the real world. But that was okay. With the frequent check-ins, we really felt that we were minimizing the likelihood of having to go back and start from scratch again once we had it live. So the check-in meetings were really helpful. And another advantage, as you'll see shortly, was the ability to have the ICMP codes visible so that staff had reinforcement of the training that we provided on ICMP codes. It also helped drive our reporting. So another big part of what we needed to keep in the back of our mind as we went through the process to figure out how we were going to build this order set was the reporting that we would have to generate. We needed to know at the front end what we would have to get out of the system at the back end, and having that in mind as we're building it allowed us to be really very efficient with our data out of the order sets. So once we had our database manager off doing the build, and in the interim, we needed to continue with the work. We had a flow chart that we use in Chartwell to help find sorry, I thought I had skipped a slide there. So we took the workflow that we had used, and this defines when we do what related to skin. And we wanted to really highlight for the nurses where the new work was going to be fitting in. And those are the red blocks with the yellow stars. So that we were able to print this, laminate it, have it up in all the nursing areas, wherever they're doing their assessments, so that it was very visual for them as to when they're doing what related to the RNAO project that we were doing. And understanding that it wasn't necessarily additional work, but really complemented and reinforced much of the work that we were doing on skin and wound. So we took our normal workflow, we sat down with the frontline staff and said, hey, let's talk about where this is all going to fit in and does this make sense. So this is a guide that they use even today to help them keep track of what needs to happen related to skin and wound. So here is a screenshot of the final product. And what you'll see here is the ICMP code. So, for example, number 1, which is an intervention, the ICMP code is right there at the top so that the staff know that it's there. They can remember what ICMP is, because if you train them now and 3 weeks later they don't see the codes, they're not going to remember what this is all about. So much of the features in the user-defined assessment area to build order sets and knowing what reports we would have to generate really drove our thinking. So go to the next slide. So an example where we used the show hide feature in PCC. And we used many different features. So in question number 5, when the nurse opens up the order set, the intervention is to assess the pressure injury using a validated wound assessment tool. And then number 5, the question 5 is, does the resident have a pressure injury? And if the answer yes, in the box below, another box opens up below, or another question below number 5 saying 5.1. If yes, A, skin ulcer assessment being completed. And it's another actually very detailed assessment that we have built in PCC. So it prompts the nurse, yes, it's done. And of course, if the nurse answers no, we're able to run a report off of question 5I and number B to see if any have been responded to as no, because if they have a pressure injury, we better make sure that we're getting the ulcer assessment completed. The reason we didn't change the title of the skin-pressure ulcer assessment is because not all of our homes are part of the RNAO project. It's only in these 2 homes where we've introduced the terminology of pressure injury as opposed to pressure ulcer. So we had to leave the title of the assessments in other areas of PCC in keeping with pressure ulcer terminology. So once we get, a little bit more advanced, then we're at the point of changing all of our terminology in Chartwell to pressure injury, which will likely happen in 2017. We'll rename everything, and that's a simple change to happen within the user-defined assessment. So here's how we report, because part of the project is being able to pull reports to submit to Enquire so that we can collate our data among all the organizations that are participating in this project to look at outcomes. So what we did, if you recall the previous screenshot where you saw the ICMP code and the intervention, if the nurse answered yes in question number 5, which I had done to open up the subsequent question, the system will auto-populate the check mark here beside 100404847 intervention 5. Using the auto feature in the user-defined assessment building process, we only now have to run a report off of one question in the user-defined assessment, and I will get a list of all residents who check mark beside 100404847 intervention 5. And I have a screenshot going forward that will show that. But this is how, when we were designing the system, we had to know what to get out of it, so that we built it in a way that we were actually able to get what we needed out of it. Otherwise, we would have had to have run reports off of every single question in the order set, and that would have been far more labor intensive than setting it up this way. So this does not answer question number 19 at all. Question number 19 gets auto-populated based on how the nurse responds to all of the interventions in the order set. And once she gets to the bottom of the order set, the system will have checked off the interventions where the nurse answered in the affirmative. What we did in our planning process was looking at where we can link what we're currently doing in MDS, because as if you work in long-term care know, MDS is a mandatory assessment tool for us. I wanted to make sure that where MDS had validated scores or outputs, that we use those where and whenever possible. So this is an example of how we link our MDS with the nursing order set, because we do get a PERS score, the pressure ulcer risk score, out of MDS. And if the PERS score was greater than 2, yes, you answer yes. And 4A would actually pop up once you answer yes, and you would put the PERS score in this assessment. So again, this is where we really plan up front really paid off big time once we got to the build. And that's, you'll see on one of the final slides, that's probably one of my #1 recommendations to people who are going forward. Don't jump to just building. Plan, and make sure you validate your planning, because it takes a lot of extra time if you have to do all that rework. Okay. And linking our interventions to care planning, and again, we relying on our care plans. We wanted to make sure that there were those reminder statements in every single order set, and we were very glad to see that there were statements around collaborating with the team, because that is a big thing for us, and also making sure that we are updating the plan of care with anything that comes out of completion of the order set. So, and with Chartwell, we've opted to, within our care plans, not give all the specific details of the current treatment for the wound, but rather we reference the nurse back to the TAR for the current treatment, knowing that the more times we would have to write something like the treatment out in detail, the chances are of transcription error and potential error for care. So that's just our process. So that's why our question is, has the care plan been updated? And question around, has the care plan been updated to reflect pain management? Because again, it's a statement in the care plan around treatment and pain management. Associated documents. So again, back to our Excel template, that was where we identified where we felt that there was additional associated documents in the best practice guideline that were referenced in the order set that we felt we wanted to add to our clinical practice to support it, enhance it, and make it better and more evidence-based. So NERDS is the perfect example of where we embedded the NERDS assessment in CC. And so when you actually get to this question in the order set, assess pressure injury for signs and symptoms of infection, if you answer question 6 as a yes, there is an infection report in PCC, then 6.1 would open up to be the NERDS assessment, and you would go through and complete that. And again, this is where the frontline staff involved, so they didn't found at the training that there was additional little bit of learning and assessing here. But when we said to them, what do you think about this? You know, it's just 5 little check boxes. Do you think this would add value? And unanimously, people said, yes, we would like it. So then when we had to go and train on it, they were the ones who had actually made the decision to embed this right in the order set. So our data extraction planning, and for those of you who use PCC, you know that PCC has a number of reports that you can generate. Being able to export or create your own report in PCC is exceptionally limited. You can build it off of it. You can pull reports off of assessments, and this is where, again, the time to think about what do we need to report. How use the features of PCC to support that so that when we build it, we get it right the first time. So actually use the Autopopulate feature to populate the ICMP codes that the nurse had answered on the assessment. And this, again, just allowed us to run one report instead of having to run a report off of every question assessment. And we'd actually get all the data that most of the data we needed related to the order set off of just one report at PCC. This slide is an example of what we were able to do. So you would see question 19 there, and we've got a number of interventions where the nurse had responded, so the system auto-populated. We would run one report, and the sections, and I've got some blocked out because I actually had to do this in a training database, and there were resident names there, so I just want to block those out. But each of the sections here would be one of the ICMP codes, and I can see for the first one that there's 7 residents where that was answered yes, so number would be 7 for whatever intervention number 1 is, and then I would take the totals for each of the ICMP codes, and we do have to manually populate the Excel template that we received from the Enquire team. And then once we have that done, we send it and upload it into the Enquire database. So it's a bit of a stepped process for us because we cannot get an Excel export out of PCC for this data. We had to add in this extra step, but by the build, we were able to make sure that it minimized the number of reports that we would have had to put together. This is one report, one run, and we can use our numbers right out of there. Okay. So step 1 in our plan was to collaborate with IT and decision support. And again, the nice thing is that I have Shauna, who is kind of that IT person, my PCC database manager. So she reports directly to me. So I was able to allocate resources appropriately for this project. And we did first start off by building the order sets in our training environment first. What the frontline staff told us when we were engaging in this process was they wanted to have hands-on experience in an environment. They just didn't want to sit through a PowerPoint of learning these order sets. They actually wanted to have it in train so that they could actually play with it and do on a few residents before they then had to do them in the live environment, which we fully supported. So we held them in training first, and then we have to actually build them in the live environment because there's no relation between our training environment and our live, so you actually have to build in both environments. We used the skincare coordinators as our initial test subjects before we even went to the staff to make sure that what we had built will work from their perspective. We didn't want to frustrate staff with something that would not flow with the workflow that they used. So again, once we did the training, we were training in about 3 to 4 hour blocks. So content, review of some basic skin information, skin and wound, anatomy, etiology of pressure injuries, all of that. And then it gave them the ability to log in, and with some case studies we had developed, they were able to actually do order sets in the training environment to see how they would function. That training allowed us to also test our data extraction plan in using that one report, and we were very happy. We did our little happy dance that actually worked exceptionally well. So, best practices. I think the first one should be obvious. Take time to plan and do not underestimate the value of really walking through what you're planning to do and getting a couple of staff who aren't part of the design team, so people who haven't been part of the discussion. Once you have your plan done, get them involved, have them come in, walk them through what you've designed and where you're going, and make sure that they can understand it and it makes sense. Front staff, again, can't underestimate this. We really learn the value of getting the people who do the work involved in the planning of the work so that they know best how things should work and how things could work. Takeaways, everybody liked to take that little flow chart away, although we did do laminated ones for each of the nursing stations. Everybody liked to have their own because they like to have their own notes on it. Extra training time for those people who aren't as familiar with PCC. Automatically, especially those of us who were working on the project, were all exceptionally computer literate, but not all of our nurses are as computer literate and computer friendly. So we did allow extra training time for those people. We had the PCC database manager go to each home for additional support if that was needed. And really what we found in having 2 sites, the homes really supported each other. So London, I know at one point went to Waterford. Waterford would call London for some help or ideas, and we were able to build a lot of synergies off of having the 2 sites involved. And then highlight the mapping to current process. And the frontline staff are there. You listen to what the staff are thinking. The last thing you want to do is hit the training and staff going, oh, great, here's another great idea that management's had that we're going to have to do. They don't really understand what we do in work environment. How can we get all of this done? We don't have time. By getting their buy-in, and the nerds piece again was a real aha for us because they actually really wanted that in there. They saw that significantly added value for us. So with that, question period. 10 minutes, I guess, for questions.
Reminder to unmute your line by pressing *7 if you have any questions. You can type in your question if you'd like into the chat box. any questions at this time, but if there are, feel free to email us and ask your question. I think on to the evaluation component now. So now, and that you enter, take a moment to tell us what you learned by attending today's presentation. It'll take less than 5 minutes, and just enter your responses into the screen to write. I mean, there was a comment that popped up on the chat just saying thank you and that it would be very beneficial for the registered staff.
Good. Registered staff, we're always hesitant to introduce news because people in long-term care, we do tend to over-assess residents. This is one initiative that I can honestly say the staff were exceptionally excited about. They see the value of doing the nursing order set, not had to do a lot of retraining. There's been some touch points back with staff, doing some one-on-one coaching, but it's more being around questions that they've had as they've dealt with individual resident scenarios. This is one thing, though, that our homes have really appreciated introducing into their environments. And it's also very significantly helped us with our CIHI quality indicator on a person stage 2 to 4 pressure ulcer. It has a stage 2 to 4 pressure ulcer in both homes. The only thing that we have changed is the introduction of the nursing order sets. And in both homes, we have seen a reduction in our Q values for the pressure or quality indicators. It's been really positive as well for us.
Thanks. So there's about 2 more minutes for anyone who is completing the survey to finish it. Remaining for the survey, and then we can move on to the final 2 slides. All right, close the poll now, so thank you. It's taking about 10 seconds to submit the responses, and then we can move on.
Okay, so this flyer is a summary of the other webinars that we are holding on our project. It's been an absolute delight working in this cross-sectoral collaborative and hearing what is happening in the other organizations that are doing order sets. So I would really strongly encourage people to participate in the upcoming webinars. You've got the dates here. They all run between 12 and 1. There's the registration link right in the presentation. And again, it's been a real joy to work with people outside of long-term care. And the session peer network collaborative learning enhances information system quality. That's where we're all going to be talking about how we kind of approach this all from different perspectives, but still within the same project. So that one's going to be exceptionally exciting as well. So I urge you to sign up for them all.
There's actually been one question.
Okay.
And the question is, have you seen a decrease in pressure injuries since initiating the order sets?
Yeah, we have seen a very significant decrease in, and primarily in long-term care, what we find are the stage 2 pressure injuries, and our numbers of has a new stage 2 to 4 pressure injury have significantly gone down in both homes.
Thank you.
So if you want more information on this nurse peer network or on the RNAO ICMP coded nursing order sets, Rita Wilson, who has been our leader at RNAO, yay Rita, contact her. Her email address is right there, and I'd like to thank everybody for participating today.
For a great presentation, very informative. Thank you for everyone for attending as well and taking the time out of your busy schedules to listen in. The slides will be made available as well as the recording on the RNAO website, and you will receive an email in the next few days with the link on how to access it. So thanks again, Debbie, and thank you to all the participants. Have a great afternoon.
Thank you.
Thanks.